Dr. Dalia Helmy, Professor of Pediatrics and Pediatric Immunology and Allergy. هنكلمنا على WAO World Allergy Organization New Guidelines for Anaphylaxis. اتفضل يا دكتور داليا.
بسم الله الرحمن الرحيم. شكرا دكتور ثروت لتقديمك يعني الكريم واللطيف كالعادة. شكرا لحضرتك وشكرا دكتور حنان ودكتور طارق for giving us the time as a team of Pediatric Allergy, Immunology and Rheumatology to present updates on this very critical topic, which is anaphylaxis that every health professional can face. I have nothing to disclose, and the content of my lecture will include the definition and causes of anaphylaxis, the clinical diagnostic criteria updated of anaphylaxis, the WAO grading system for systemic allergic reactions, and management of anaphylaxis. I'm starting with presenting the WAO Allergy Organization Anaphylaxis Guiding published 2020. With our belated Professor Dalia Helmy EL-Ghoneimy was a co-author on this very important publication. The WAO anaphylaxis guidance has been developed primarily for use not only by allergist immunologists but by every health professional, and including the allied health professional like nurses dealing with patients, caring for patients at any ages, especially those dealing in emergency and perioperative settings. Starting with the definitions, anaphylaxis is a serious systemic hypersensitivity reaction that is usually rapid in onset and may cause death. Severe anaphylaxis, its grades as we will see, is characterized by potentially life-threatening compromise in airway, breathing, and or circulation, and a very important point that it might occur without typical skin features or circulatory shock. However, some anaphylaxis definitions like this proposed by the National Institute of Allergy and Infectious Disease, which ascertain the need of multiple organ involvement, such a definition is misleading and can lead to inappropriate treatment because of failure to recognize that this patient is facing anaphylaxis. Types and triggers of anaphylaxis. Anaphylaxis could occur through immunoglobulin E-dependent immunologically mediated process, which most commonly caused by medications, biologicals, chemotherapeutic agents, antibiotics on the top of the list, different food, and the prevalence of causative food agents somehow differ by the region. For example, in Middle Eastern and North Africa, sesame, milk, and egg are the most common, while in North America it's the shellfish and the tree nuts. Also by the insect venom, aeroallergen, even mite, dust mite can cause anaphylaxis. The latex, so we can see radiocontrast media. So radiocontrast media can induce immunoglobulin E-dependent mechanism, and at the same time can induce non-immunoglobulin E-mediated immunological anaphylaxis. So we can see that every subspecialty can encounter anaphylaxis. And non-immunoglobulin E-mediated, like drugs, radiocontrast media, and biological agents, and this can be mediated through the complement system, coagulation contact system. The non-immunologically mediated is through direct mast cell degranulation through acting on a specific receptor named mass complex G receptor, coupled receptor, and this is through the physical exercise, some ethanol, alcohol, and some medications like the opioid. Idiopathic means no identified trigger after the resolution of the attack, and on assessment of the patient, no identified triggers, but somehow when currently new allergens are discovered, these terms somehow confined to a very small proportions of anaphylaxis. This is examples that are newly identified allergens like alpha-gal, like oilsine, some with more intervention and like introduction of new drugs like biologicals and chemotherapeutics. These are anaphylaxis episodes are more frequently recognized. There are just not only triggers, but there are factors and cofactors influencing the occurrence of anaphylaxis, triggering its course and amplifications of the consequences. Like concomitant disease, if this patient has uncontrolled asthma, allergic rhinitis, eczema, cardiovascular disease, somehow undiagnosed mastocytosis, or even if diagnosed and severe systemic mastocytosis, and some psychiatric illness like antidepressant because it interferes with the recognition, early recognition of these symptoms. Somehow age-related factors like infant, they cannot describe what they feel. The adolescent and young adult, because they are more risk takers. Somehow it's away, but it's just indicated for all age categories. In labor and delivery, because the mother are exposed to more drugs with somehow hemodynamic borderline, and the elderly because of the concomitant diseases and medication they receive. Also, if the patient receiving beta blockers, AC inhibitor, angiotensin converting enzyme inhibitor, this trigger and amplify the occurrence of anaphylaxis, or alcohols, exercising, acute infection, sleep deprivation, and premenstrual stage. Some said or suggest that some females have hypersensitivity reactions against progesterone and the estrogen. So coming to the updates in the clinical diagnostic criteria of anaphylaxis, anaphylaxis is highly likely and considered when any one of the following two criteria is fulfilled. First, acute onset of illness. Acute means within minutes to several hours. However, some allergen-induced delayed onset like alpha-gal that is present in meat and some drugs, with simultaneous involvement of the skin, mucosal tissue or pus in form of generalized hives, urticaria, even pruritus only or flushing, sense of intense heating, swollen lips, tongue, and uvula. And at least one of the following: airway breathing compromise, dyspnea, wheezes, stridor, hypoxemia, and low peak expiratory flow if available, reduced blood pressure or associated symptoms of end organ dysfunction in terms of collapse, hypotonia, or incontinence, severe and not persistent GIT symptom. It's not essential to be persistent, but just severe, like severe crampy abdominal pain, repetitive vomiting, especially if occurred after non-food allergen exposure. Second criterion is acute onset of hypotension or bronchospasm or laryngeal involvement. The previous guidelines released included only acute onset of hypotension as a single criterion. However, if now occurred acute onset of bronchospasm or laryngeal involvement like stridor, like odynophagia, painful swallowing, dysphonia, after exposure to known or highly probable allergen for this patient within minutes to several hours, even in absence of typical skin involvement or other criteria, this is considered as anaphylaxis. And this is the criteria for considering hypotension, which is like greater than 30% decrease in the systolic blood pressure in infant and children, and in adult less than 90 millimeter mercury, or even decrease more than 30% from the baseline. Some reactions, this is very important, present initially with isolated respiratory or cardiovascular system. Such presentation are not uncommon in fatal anaphylaxis triggered by exposure to food and other allergens, and interestingly and very important, with oral immunotherapy or drug desensitization protocols. And this must be considered as anaphylaxis and managed accordingly. So involvement of only one system with respiratory or cardiovascular compromise should not mask the recognition of this attack as anaphylaxis and prompt treatment. Around half of the biphasic reactions mean that after initial improvement, the patient will have recurrence of the system, can occur within the first 6-12 hours. However, it can occur after 72 hours. Patients with anaphylaxis need to be observed, and this is very important in severe reaction and those requiring multiple doses of epinephrine, and this is necessitates that your patient should be observed for at least 12 hours, and in severe cases, he might need admission for at least 48 hours. And now the WAO systemic allergic reaction grading system, they grade the systemic allergic reaction. The World Allergy Organization first put this grading system for the systemic allergic reaction after immunotherapy, and then they generalize this grading system for any systemic allergic reaction occurred. The aim is to grade the anaphylaxis severity and to differentiate between what's not anaphylaxis but systemic allergic reaction and anaphylaxis. They consider grade 1 and grade 2 as not anaphylaxis reaction, although systemic, but they are not rising to the definition of anaphylaxis. Grade 1, and we can see that grade 1 just involving urticaria. It is systemic. Why? Because it is away from the site of exposure to the allergen, and just tingling in the lips and maybe angioedema, but however not ever involving the lips. Involving the larynx, so the patient doesn't have a stridor. Upper respiratory involvement like sneezing, rhinorrhea, we can see that all is mild symptoms, although they are systemic. Some cough, but not bronchospasm, conjunctival erythema, pruritus, or even metallic taste, but they are all mild. And the grade 2 is symptoms from grade 1 involving 2 or more organs, but they are from grade 1. Coming to the grading of anaphylaxis, grade 3 involving now the lower airway, but it is bronchospasm responding to treatment. When giving treatment, it is responding. However, it is have gastrointestinal, abdominal cramps, diarrhea or vomiting, and uterine cramps, and they might have symptoms from grade 1, including like sneezing, rhinorrhea, tingling or itching of the lips. So grade 4, lower airway involvement, but this is severe bronchospasm, not responding or worsening in spite of receiving treatment. Now the upper airway involvement is in the terms of angioedema of the larynx with a stridor. This is severe. And symptom or sign from grade 1 or 3. Grade 5, which is the most severe and serious, and they might increase fatality rates. Lower or upper airway means severe bronchospasm or angioedema, but with impending respiratory failure or respiratory failure. And the patient might have cardiovascular collapse, hypotension. They might have loss of consciousness, and we have to exclude vasovagal. Vasovagal, the patient is bradycardic and pale. And any symptom from grade 1, 3, or 4 would be included. However, this, whether grade 3, grade 4, grade 5, the treatment of anaphylaxis should be implemented once it is diagnosed and recognized. It's not about mild anaphylaxis not to give the proper treatment and severe anaphylaxis to give. No, the treatment of anaphylaxis once diagnosed is the same. However, the period of follow-up the doses of anaphylaxis expected to be given that are the points that differ between the grades of anaphylaxis. Differential diagnosis of anaphylaxis: acute severe asthma exacerbation, localized angioedema only just in the eyes, not involving or apply to the criteria of anaphylaxis, hereditary angioedema, syncope, anxiety and panic attack, and these patients have hypertension, carcinoid syndrome because of the flushing, food poisoning, and red mantle syndrome because of rapid administration of vancomycin. Just as we will see the assessment of the patients with anaphylaxis, we can just exclude many of these differential diagnoses. And even in cases of hereditary angioedema, if you cannot discriminate in the first encounter of this patient, give the patient just the safest dose of epinephrine, as we will see, save him, and then take detailed history. Concerning the diagnostic test in acute anaphylaxis, actually there are no many to depend on in the acute episode, and serum tryptase level peak between 1 and 2 hours after the onset, although normal level does not exclude anaphylaxis as in food-induced anaphylaxis. And it is most important that, like to measure the baseline tryptase level to diagnose or to suspect mastocytosis, because even normal tryptase level does not exclude systemic mastocytosis, and we need genetic testing. Treatment of anaphylaxis include acute and long-term management. The acute treatment of anaphylaxis means that this patient, if he is on his own, he might have, and this is a recurrence, or a known allergic patient with previous anaphylaxis episode, he must have a written emergency protocol, removal exposure to the trigger. So if the patient has been receiving a drug, just disconnect rapidly, assess the patient's airway, breathing, circulation, mental status, skin and body weight, call for help, intramuscular injection of adrenaline, positioning of the patient with raising his legs up. Okay, this should be occur simultaneously, and never to delay the intramuscular injection of adrenaline, as we will see it's a protocol of administration. And we have to know that letting the patient to stand up can kill the patient within seconds because of distributive shock. Oxygen therapy if indicated and having respiratory compromise, intravenous access for IV saline if needed, the patient is shocked. If nothing and the patient enter in cardiopulmonary collapse, consider CPR, frequent monitoring, and even continuous monitoring for severe cases for vital data and oxygen saturation. The recommended doses for intramuscular epinephrine, and this should be studied and known by heart. It is 0.01 milligram per kg injected intramuscularly in the vastus lateralis portion of the thigh, means the anterolateral part of the thigh in the mid-thigh, and calculate the time of administration. Know the time of administration of intramuscular adrenaline, because it can be repeated after 5 to 15 minutes if the patient did not respond initially. The maximum dose for children under less than 50 kilogram is 0.3, and above 50 kilogram, like an adult, is 0.5 milligram. What about other lines of therapy? Intravenous first generation antihistamine is never and would never be the first, second, third line of treatment of anaphylaxis. It should not be considered at all, except after the stabilization of the patient, resolution of anaphylaxis. If he has just residual itching, pruritus, you can give first generation antihistamine, but it should not be considered as first, second, or even third line of treatment. Corticosteroids, also it is just like as improvement of if he has residual bronchospasm, but it's not among the main line of treatment, first, second, or third. First, second, third line of treatment is epinephrine. And nebulized beta-2 stimulant is given if there is bronchospasm, and should never be an alternative for intramuscular epinephrine in anaphylaxis. If refractory cases, transfer the patient to the ICU and give intravenous epinephrine through central line, slow infusion, however by concentration 1 to 10,000. It is very important to know that the concentration of epinephrine given in intramuscular is 1 to 1,000 اللي هو 1 مللي جرام في ال 1 مللي اللي موجود عادي الصيدليات خلاص. لكن الانترافينوس انفيوجن ده دايليوتد 1 ل 10,000. اللخبطه والميكسنج can kill the patient. خلاص اوكي. If not responding, vasopressor, dopamine, intubation. If the patient has respiratory failure, not خلاص يعني should be ventilated. Glucagon, especially if the patient receiving beta blocker, which make the response to epinephrine very difficult, if any. Atropine, persistent bradycardia, tracheostomy rarely needed لو العيان يعني recognized من الأول. Long-term management of anaphylaxis. It's a fatal mistake. Even if you treat the patient and give him adrenaline to discharge the patient without giving him a long-term management protocol and ask him and instruct him to visit an allergy or immunology specialist. So we have to give the patient emergency action plan and bracelet identification that this patient has anaphylaxis to food, to something, and then after 3 to 4 weeks, he pay a visit to the allergist, okay, and to do skin testing or specific immunoglobulin E. Why we don't do skin testing or specific immunoglobulin E before this period? Because during the anaphylaxis episode, this specific immunoglobulin E are consumed in this anaphylactic reaction. So this testing the patient earlier will give false negative results, as if the patient has idiopathic anaphylaxis, which is not true, okay? And then if the patient is a candidate for immunotherapy, we can arrange for this. And if he has food allergy, there is a strict avoidance. Till now, there is no validated protocol for food immunotherapy. And he has to get epinephrine, auto-injector, or alternative زي عندنا في مصر, because we don't have epinephrine auto-injector. Although it is very essential, but it is not present. This one, the rectangular one, is associated with sound system because it just gives instruction to the patient. Just inject as an anterolateral part of the soil and wait for 3 to 10 seconds before removal the epinephrine auto-injector. So after injecting the epinephrine, we do not remove the EpiPen or at once, but should be remained in place for 3 to 10 seconds. Just count 1, 2, 3, 4. This epinephrine auto-injector, the rectangular one associated with sound system, just guide the patient when to remove it. Okay, and it is adjusted with the dose either 0.3, either 0.5 or 0.15 milligram for patient weighing less than 15 kilogram. This is a technical point in the epinephrine auto-injector. احنا مريحين نفسنا وهي مش موجوده في مصر اصلا، يعني ايه اللي هي لو هو 0.3 milligram and the patient is thin, it might reach like intraosseous injection. So we have this keep the need to make epinephrine auto-injector 0.15 for young small size. And in fat people with the small needle of the epinephrine, just as if it is injected subcutaneous instead of intramuscular. But however, these are adjusted to make the needle suitable for obese and the smaller doses for young small children. Alternative formulation ده اللي يهمنا. epinephrine auto-injector عندنا included pre-filled epinephrine syringe لها بالدوز، اوكي، ونحسبها العين. بس ايه بقى؟ لازم تبقى protected from light انها بتبوظ، ولازم تتغير every 3 to 4 months لانه هيبقى spontaneously disintegrated ويبوظ. تاني حاجه بس طبعا احنا يعني ده صعب، يعني احنا we are patients are يعني هم لوحدهم هيجي لهم anxiety، لانه النقطه الثانيه انا اقول للعيان انت هات سرنجه 1 مللي سرنج اللي هي بتاعت الانسولين والابنفرين ادرينالين. during الاتاك بقى خد الجرعه من الابنفرين واملاها. ده يعني much more difficult because the anxiety associating the episode شخصيا will make things more trembling and difficult for the patients. And at the end, I would like to thank the team of Pediatric Allergy Immunology ودكتور يحيى الجمل الله يرحمه ويحسن إليه who founded this unit. And working together at the end is very important to recognize anaphylaxis and its treatment, avoid anaphylaxis-related mortality, and prevent recurrence because this is unavoidable mortality. And thank you very much for your attention.